Today we're going to learn about IPAPs, or Institutional Patient Assistance Program, and best practices for success. Before we get started, we're just going to start out with a couple polls just to sort of get a feel for who's attending this webinar. So we're going to start with the first one right now. Okay, so what is your role in your organization? Please select one of the following: Executive Director, Pharmacy Staff Volunteer, Eligibility Screener, Clinical Staff or Volunteer, or Other. Go ahead and start responding, and we'll give you a minute. Okay, just another second. Okay, so looks like we have 3% Executive Director, 14% Pharmacy Staff Volunteer, 17% Eligibility Screener, 20% Clinical Staff, and 46% Others. So we're going to start with the next poll. How familiar are you with bulk patient assistance programs, also known as IPAP? Please select one of the following. Very, we have one or more bulk contracts. Somewhat, are considering it for our organization. Not very, have heard of it but limited knowledge, or not at all. So go ahead and start voting. Okay, just another second. Okay, so it looks like we're pretty split. We have just about 19 who are very familiar, 14% are somewhat. Looks like the majority, 39%, are not very familiar. We have 28% who are not at all familiar. So hopefully everyone will learn a lot from this. Just one more poll. What are you most interested in learning today? What is an IPAP and how can we participate? Some key tips for eligibility screening, individual and bulk. Self-auditing and training staff to improve success, or other. Go ahead and start voting. Okay, just another second. Okay, so it looks like we have about 50% who want to learn about what an IPAP is and how we can participate. 37% want some key tips, and 13% want some information on self-auditing and training staff. So thank you all for doing those polls, and we will go ahead and get started. So just to introduce our guest host, one moment. And that's going to be Amy Yarcich. She's the Executive Director of RX Partnership, a nonprofit public-private partnership dedicated to increasing access to medications for people in Virginia. So Amy, would you like to take it away for us?
Sure. Thanks so much, everybody, for joining me. You should be seeing my screen right now, which is an introduction to IPAP and the RX Partnership logo. Let's see. Is that working all right?
Yep, looks like everything's working.
Okay, great.
And again,
what I wanted to do today, and it was really helpful to have those few poll questions just to kind of get a sense of the audience and what will be most useful for you. I'm going to talk to you definitely about IPAP in general, bring some folks up to speed who may not have heard too much in the past, but then get into more specific information that I think is going to be valuable, whether your focus is on purely individual patient assistance applications or working in a bulk situation, because the eligibility screening and doing that to the best degree possible really makes all the difference in the world. So that's something that's common no matter which way you're accessing the medications from the pharmaceutical companies. So just to kind of get started with things, I did want to be able to just kind of give you a little bit of background about, you know, why would somebody want to do bulk access to medication? Why not just do the individual applications, which I'm assuming most folks on the line have done to some degree. It might be exclusively, it might be in combination. And I think they're certainly a wonderful resource, and it's a way for folks who don't otherwise have access to medication to be able to get them. But of course there's challenges, and a lot of it comes from simple volume issues. We've got more and more patients, a lot of our folks that we work with have seen about a 30% increase in the number of patients in the last year. And then when you drill down and think about how many medications each of those patients are on, many of them have a chronic condition. Many of them even approach a free clinic, particularly when they are quite ill already. So it does mean that they're taking an average of about 4 to 6 different medications and 4 or more different companies, which can certainly be challenging in a paperwork perspective if you're writing away for the individual patient assistance programs to those different companies. We do find that different pharmaceutical companies change their eligibility criteria and which drugs are available. That can lead you back to the drawing board in terms of doing more paperwork. Also, sometimes when patients get changed from one dosage strength to another, which is appropriate from the medical perspective and best for the patient, and yet it can cause a lot of challenges if you have to go back to writing out another application for that. Waiting periods, I feel like, have improved a whole lot compared to years and years ago when you think about how long you can get, how long it takes to get the individual meds these days. It's really improved, but sometimes it can be a couple weeks or longer. And so certainly the reason to look at IPAP, to look at bulk, is to be able to say, here's medication on the shelf, ready to go. If you change a dosage strength, you just take the other bottle off the shelf to dispense to a person. You are getting access to all of these meds at once without having to do individual applications for each. So it's kind of an ease motivation primarily. And I think it's not going to do away with the need for individual applications, certainly, but I think it's about all of us having to be very resourceful in figuring out the best way to get all of the medications that patients in need require. And so it takes some creative thinking and using more than just one approach. So just to think about kind of another bit of background research, there are certainly costs to completing those individual applications, and sometimes we don't think about that too much because we're using, say, a lot of volunteer labor to be able to complete those applications, but it can really add up in the long term when you think about how much time is spent that maybe could be spent doing something else, and even why a lot of folks may not even participate in individual PAP applications. It's just that it's too time-consuming and complex. So I think we have to consider that there are costs associated with it, not to say there isn't with having pharmacy and a bulk contract, but there are ways of sort of looking at that and saying if you already have the pharmacy in place or if you have access to volunteer pharmacist labor and can keep some of the other costs down, it can actually be pretty cost effective to do a bulk program and run your patient assistance applications individually as a sort of supplement and a companion program. So just to get now more into the nitty-gritty of what is an IPAP, and I'm using those terms kind of interchangeably as far as bulk and IPAP. Essentially, sometimes people are a little bit clearer on the bulk side of it, but just to kind of boil it down, we're looking at patient assistance program medication that's being provided to a clinic, and it's not designated for certain individual patients the way it is when you do an individual patient assistance application. It doesn't show up in a bottle labeled for John Smith. It comes in a quantity of bottles on the shelves, and then the eligibility screening process that the clinic undertakes, it's a reporting about what was dispensed out to those eligible patients. So it's about having medication on the shelf ready to go and dispensing it out to those eligible patients and then reporting who you gave it to that was eligible, whereas with the individual PAPs, you're on the front end sending in the paperwork to say who's eligible, here's all their paperwork, it's being sent off somewhere else to be reviewed, approved, and then medication sent back specifically for that one person. And I think what we're seeing more and more now, too, are some of the programs where for individual patient assistance programs, if that medication isn't picked up by the individual, a lot of the programs now are requiring that that medication be destroyed, which is a little different than I think the practice had been in the past, where that was then eligible to be given out to someone else. And so you could find yourself doing a lot of work to apply for these different individual programs and then not having medication, for that person. They've moved on, something like that, and then you're left with having to destroy or send back that medication. Just to give a quick kind of summary, there's different types of institutional patient assistance programs. Maybe a large clinic might have a relationship with, say, AstraZeneca or Alcon or GSK and have that bulk medication sent to their clinic. There are some states that use a warehouse model where essentially the medication is sent to one central location and then sent out to either individuals directly to their homes or to different clinic facilities, Well Vista, West Virginia RX, places like that. Then you'll see this broker model. That's where RX Partnership is a little different from other organizations, and I'll talk more about how we got started and what that broker model means. And I believe, you know, in keeping tabs on what's going around the country, there are other types of situations where those IPAPs are being utilized. Sometimes they're in a safety net hospital situation. It just sort of varies around the country. But to get down to like why would it be beneficial to do an IPAP, and the patient perspective is of course something that we try to keep in the forefront of our mind. But for them, a patient, they're able to get that medication immediately. They're not having to wait for it, come back to the clinic. Maybe some transportation issues can be a real problem. And then, of course, paperwork reduction, the fact that they can be eligible for clinic services, bring in the financial documentation they need, and then be eligible for any of the medications that facility can access in bulk for a full year's time versus the kind of additional paperwork associated with the individual program, which sometimes has to be done even on a quarterly basis. So this is one of the patients that RX Partnership has helped assist through the free clinic of the New River Valley. And I think it's really telling that, you know, for this person, being able to work, being able to really get their life kind of back on track because of the access to medication has just made a huge difference. But I do also want to consider that there's benefits to IPAP from the clinic perspective as well. For the clinics, to be able to use their limited resources in the most effective way is something that they're always trying to streamline and work towards high efficiency. So it's a matter of using the staff and volunteer time as effectively as possible, having some consistent systems in place, saving time and, of course, saving money. And certainly for any clinic that might have a pharmacy that right now is doing more in terms of purchasing medications, or there are organizations that might send someone to a local pharmacy and have the clinic billed for it. And while a $4 formulary can be very helpful, it can also be a little challenging in that you don't know for sure when and if the patient is getting those fills. And for someone who may be on, say, 4 or 5 different medications, $4 times the number of medications can add up and maybe lead to a situation where they're selectively filling certain medications. So certainly doing whatever we can to be able to, in a quick and easy way, get those clinics the medication they need to get out to the patients makes their lives a lot easier as well. So now to drill down more into RX Partnership specifically and how we got started and what it means in terms of other organizations doing an IPAP. Our organization got started when some safety net folks got together and just realized there must be a better way, in addition to just using the individual patient assistance program, to be able to get medication. We're realizing that access really does play a large role in medication adherence and those better health outcomes. So anything that we can do to more quickly and efficiently get medication into people's hands is a benefit. So what RX Partnership did was develop this broker system, and what that means is that I'm working for a small nonprofit based in Richmond, Virginia, and serving clinics across the state of Virginia. So my role is to coordinate the flow of this medication to the clinics and the flow of information in terms of dispensing data back to the pharmaceutical companies. But I'm in an office, there's no pharmacy here, there's no medication that comes through here. I'm kind of a middleman coordinating and making sure that the medication gets where it's supposed to be and that data gets back. We manage the contracts and the relationships, but we don't actually have a pharmacy. So it's kind of an interesting position to be in. We were incorporated back in 2003. We are a nonprofit. We get support from the Virginia General Assembly, so we have some government support, but a large part of our budget is made up of healthcare-related foundations. We have some corporate support, and then we call them affiliates. The clinics that receive the medication through us are actually also a part of our organization in terms of helping to direct what we do and be a buyer, kind of buying into this process. So we do also have on our board someone from the Virginia Board of Pharmacy as an ex officio member, and that was really helpful in making sure that we were setting up our systems correctly, and then certainly addressing any kind of pharmacy-related questions that may come up throughout the year. Trying to take what I know may sound like a slightly complicated system and boil it down, we've got this quick diagram here to just show you a little bit of how this process works. So we've got the pharmaceutical companies donating the medication, and that medication is actually going, you see the picture of the pills, going directly over to the clinics. Now, our partnership comes into the equation because we're telling the pharmaceutical companies what it is the clinics need in terms of product initially for an initial stocking, and then the replacement that they need after they've reported what they actually use. So the medication goes from the pharmaceutical company directly to the clinics, and then the clinics get it out to the patients. On the other hand, the clinics are reporting in through their pharmacy software what's been dispensed out, and once a month sending that information to Rx Partnership, and then we format it to the way that each different pharmaceutical company wants to receive that data. We have 6 pharmaceutical partners, each one a little different in terms of how they want to receive data. The clinics, it's kept fairly simple because they can just upload from their pharmacy computer their dispensing information. We then take it and put it into the different formats that are needed for each company and send it on. And then that just sort of completes the loop in that then the replacement medication is sent to the clinics, dispensed out, more data reported, more product replaced, and it kind of circles through, and we maintain a inventory on the shelf of each clinic so that by the time their next shipment is received, they haven't depleted their entire supply, so they are able to continuously provide what their patients need. So looking at kind of the impacts of this in Virginia, and certainly, you know, each clinic maintains data on the number of patients and the number of prescriptions and the dollar value that's impacted their clinic and their local region. Cumulatively, we're looking at the last fiscal year, July 1st of 2011 through June 30th of 2012, over 15,000 uninsured Virginians, over 85,000 prescriptions with a dollar value of about $20 million. And this is all, you know, free medication that we were able to coordinate being sent and distributed through that network of clinics with pharmacies. So our overall numbers, since we started doing product shipments in 2004, we're looking at some pretty impressive numbers. I think what we've seen as well is that the numbers are getting larger each year. So if you were to look at it, it would be a kind of charting a graph that's got that very steep upward curve, especially in recent years where there's been just higher volume of medication needed and supplied. And that's where we're fortunate that the pharmaceutical companies have these programs in place and are not limiting the supply of medications available. It's just maintaining the systems and the reporting that's needed to access it. So in terms of participating in an IPAP and what it would mean for folks who might be listening on the line today who are considering it, we find that the requirements are very similar to what Rx Partnership requires of our affiliate clinics. So what we do is sort of take on the role of coordinating those contracts and kind of supervising the process so that the clinics don't individually have to have multiple contracts with different pharmaceutical companies and manage them. So that's our partnerships role, but the same holds true in that any of our clinics could go directly and have relationships with pharmaceutical companies, just the way many of you on the line might explore those bulk contracts and see about exploring an IPAP. So certainly being a nonprofit, tax-exempt organization, being established, sustainable, sometimes they will ask to see a 990. Other things just to show that you are able to, you're in business, staying in business with all the practices that are needed in order to assure success. In terms of things that have become even more essential, I think, in recent years, is the quality of your standard operating procedures, knowing that beyond just having a system for doing something, it's written down, it's documented. Certainly when it comes to how you go about doing eligibility screening, how you go about maintaining and running the pharmacy. And in terms of the eligibility, while each pharmaceutical company's individual program may vary a little bit, what Rx Partnership has done is looked at a standard that is consistent across the different companies. So for our purposes, it's 200% or less of federal poverty level, no prescription drug coverage. For us, it's a Virginia residency piece, but for a lot of pharmaceutical companies, you know, that percentage of FPL may vary by the individual company, but certainly there are requirements for financial eligibility that you have to keep in mind. In terms of an IPAP, also having that on-site licensed pharmacy and staff, they're going to ask to see your pharmacy permit, your pharmacist in charge license. This is the kind of thing that, you know, it's just sort of a paperwork piece each year to provide the updated copy of that. And certainly the second bullet on this slide is very key because it's a matter of being able to engage in the tracking, monitoring, reporting, and evaluation. I mentioned about how each company has a different format for it, but they want much of the data to be similar in terms of having a unique patient identifier, not the patient's name or their social security number. As a best practice, we're looking at a number that is not somehow able to be linked to a particular patient, random number, or somehow a system-generated number, but a unique patient identifier. And then you're needing to be able to generate a report that shows the quantity of what medication, the NDC number, dispensed on what date. Some companies ask for additional data about the sex of the patient or the date of birth, date supply of medication, but that varies from company to company. But at the core, if you can generate all of those different data elements, then you'll be able to provide them when needed in the format that's needed. And it can take a little bit of time in order to put the data into the correct format for each company. Some of them will have an Excel spreadsheet. Some of them will ask you to upload the data to a system that they've generated through their company. It can vary a lot. Rx Partnership is fortunate in that we designed a specific system several years ago that allows us to take this raw data from the pharmacy software systems, whichever one's being used by a particular clinic, and essentially flow that data into the correct format for each of the 6 companies we work with. So that's something that has streamlined and saved a lot of time and energy both for clinics and for Rx Partnership. We're looking at making that system more widely available in this next year for other clinics around the country to use if they're interested. But at this point, if you were to join an IPAP, you'd have to just make sure you were figuring out a way to get those different data elements into the format required by the company. In terms of participating in an IPAP, just some of those other bullet points here, it's certainly having the pharmacy systems and security to maintain that project and prevent any kind of diversion. Also then being able to successfully complete different audits. And it varies from pharmaceutical company to pharmaceutical company in terms of how often those audits get completed. Some of them, more of them these days, require a kind of pre-audit before you join their program. And then typically it can be annually after that, where they'll come on site, look at about 100 patient files, double checking to make sure that you did have all of the eligibility documentation in place and the financials before you gave them that program product that was sent to you in bulk. So whereas there's not the sort of audit element when you're doing an individual patient assistance program, you find out if you didn't have all the right data elements when it gets sent back to you. It has to be resubmitted. In this case, it's a matter of passing these audits each year to maintain your participation in the program, making sure you're doing what you need to be doing all along so that when that audit does take place, you come through with flying colors. So if folks are learning more about IPAP and thinking this is something that's appealing to you, you feel like based on those last 2 slides, you have many of those things already in place and the capacity to be able to take this on. You certainly want to sort of do your homework, be as prepared as possible. We find that it's helpful to know what your clinic needs and sort of target your approach. I would say based on any clinics who are doing individual patient assistance applications, you know which companies you're submitting the most applications to, and realize that that could be a good starting point as far as which companies you might want to form a relationship with as an IPAP, because that would reduce the burden on the individual applications, which would save both you and the pharmaceutical company in the end some time and money. So it's looking at targeting your approach, being able to understand and know what quantity of medications you would need initially from which companies would have the most impact in terms of saving you time and energy, and looking at strategizing on your approach based on that. Now, it is important also to do a little bit of kind of research out there. It can be challenging finding out which pharmaceutical companies have an IPAP, and is it, quote, open, which it just appears that depending on internal company operations, they may be taking on new partners. They may be kind of in a holding pattern for a period of time and then reopen to take on new partners, but it doesn't hurt to ask. And I certainly think that there are some companies that are a little bit more open in terms of promoting the availability of their IPAP program. AstraZeneca is one where you can find information on their website about their kind of clinic facility program. Alcon is another one. Beyond that, I would say, look at spending a little time browsing. If you're able to attend a conference where the different pharmaceutical companies are present, that gives you a lot more information. And one particularly good one is the CBI, Patient Assistance and Access Conference, that takes place each year, March in Baltimore. They're doing a half-yearly one in Philadelphia coming up in about another couple weeks, but the main one is March in Baltimore. So that's a chance to meet some people in person, talk to other folks who are managing IPAPs, and kind of learn from their experience. But definitely it's a matter of trying to get to the right person at the company. Sometimes you might approach it through a kind of government affairs angle, working with folks in your state and realizing which companies have a large presence in your state. Other times it could be through a more patient assistance foundation kind of angle. But I think you have to do your research, be ready, realize that it is going to take some time. It's not something that you can snap your fingers and have happen overnight. Even once you've kind of found a company that seems open, you're going to have to go through their application process and provide them with a lot of different documents. Those standard operating procedures I mentioned are really crucial. They may ask you to make some tweak changes to them in order to comply with their business rules. The audit process, the pre-audit process of joining with a company for an IPAP is really very informational in that they're trying to get you the details that you need in order to participate successfully. So don't look at it as them trying to necessarily keep you out of the program, but by doing what they do, they're ensuring that it's going to be a valuable relationship for the company and for the facility as well. So you know this is going to be hard work, but I think it can be very worth it. What I want to do right now is maybe just take a pause. I don't know, do we have any questions at this point that have been typed in?
Looks like we have one question.
Okay.
I'm just going to read through it. It's a little long. It says, can patients be referred to hospitals, clinics, pharmacies participating in these programs?
Well,
is there? I guess she's wanting to know if there's a list if patients need medications urgently.
Well, I guess if I'm understanding the question right, I mean, the way that it works in Virginia is that we have got these 23 different clinics that participate with our partnership, and some of them have relationships with their local hospitals so that when patients are being discharged, they will coordinate with the free clinic locally in order to do the eligibility screening and financial documentation and more quickly get them maybe an appointment, a follow-up appointment, or the medication that they need. But in terms of the IPAPs themselves, these are maintained in different ways kind of around the country, and it would just be, coordinating with a local program to see if they're in a position to be able to serve the patient that's needing some medications. It's probably going to be based more on sort of geography.
Okay. Were there any other questions before Amy continues? Doesn't look like there's any right now. Just also a quick side note, NeedyMeds also attends that conference in Baltimore every year, the CBI conference, and it really is a really great place to meet all the different pharmaceutical companies and all the different kinds of, foundations and nonprofits like NeedyMeds and our partnership, kind of getting out there to try to help people access medications. So, it's not just for the pharmaceutical companies. There are advocates and people from clinics and facilities, healthcare facilities that come. So I would definitely, check out their website and see if you'd like to maybe attend this March. The name of the conference is the CBI what is it called? The Patient Access Conference, I think is what they call it.
Patient Assisted Access.
Right, yeah. So if you just Google that, you'll be able to find it. I also believe there might be, we may have taken it down. We usually put a link up when we, start planning to go. Last year, actually, NeedyMeds shared an advocate track, and we're thinking about doing that again this year. So, yeah, if you just Google CBI Patient Assisted and Access Conference, you should be able to find it. It's in Baltimore every March. Any other questions? All right, Amy, you want to keep going?
Okay, yes, and that was a good natural breaking point in that. What I'm going to do now is transition to talking a little bit more about some of those things that need to be done for eligibility screening, whether you are looking at a IPAP, or these are tips that I hope will also be helpful if you're looking at doing individual applications and just trying to make sure that you have the right information for patients in order to be able to get them their medication as quickly as possible. So transitioning a little bit now to how we ensure that folks have continued access to free medication, and that is really where it comes into the audit process of making sure that the 23 clinics that I mentioned that work with us are all doing what they need to be doing individually in order to have the documentation on file, ensure that the medication that they have on the shelves and in bulk to then dispense out to patients is going to only eligible patients. So we maintain a strong relationship with the clinics and with the pharmaceutical companies through regular communication, this data reporting that takes place, and then what we have done is taken on the role of auditing each of our 23 affiliate clinics every year so that when and if the pharmaceutical company does their audit, everything is in place, the systems, the adjustments have been made and the training has taken place so that we know that our partnership is going to pass that pharmaceutical company audit and be able to continue to maintain that contracted relationship and get the medication in bulk for everyone. So this is where you're only as strong as your weakest link, and we've got to make sure that all of our clinics, all of those eligibility screeners working at all those different clinics are doing the best job possible and really understand why what they're doing is so important. So audits benefit the manufacturer, but also the facility, because it can provide you with some information about how to make some enhancements. So they're certainly looking at policy and procedures, troubleshooting problems, making sure it's compliant with their business rules, and that's where it can be challenging because each company may have slightly different rules, and you've got to, if you have multiple IPAP contracts, make sure that your SOPs and your rules encompass the differences that might come into each of them. So as I said, that's where our partnership mandates a 200% or less federal poverty level threshold, whereas some companies might be up at 400 or 250. Instead of having to think and kind of bounce back and forth and maybe make a slip up in terms of eligibility, considering the free clinic population in Virginia, that consistency of 200% seems to work very effectively. What I was going to just briefly show you in terms of the audit process, I think audits are something that you can do yourself internally, and it's a good best practice to be double checking in on yourself, whether you're looking at different work that's been submitted for individual applications, or in our case, this is actually our access reporting system that we use, our access auditing system. We have this custom developed, and for us it's a huge benefit in that when we go on site and we're looking at 50 files for a particular clinic, we'll pull this data randomly from what they've reported into us over the past year, flow in some information into the form. You can see we've got some information already plugged in about what was dispensed on what date. Then we are able to pretty quickly and easily kind of pop through, put in the date they were screened. It has to be within a year of the date dispensed, and if that happens, this little box up here that's red pops to green with a little Y for yes. We fill in these other information that needs to be completed, understanding what the household size is and what the income, the gross income was, and how we documented that, whether it was from a tax return or pay stubs. And essentially that's our way of auditing the clinics and making sure that they're maintaining the right eligibility screening that they need. Because it is so crucial, it really is important to do what you can to really, thank those eligibility screeners for their hard work, give them the tools and resources that they need to succeed, and that's where training really makes such a huge difference. It's a matter of you can't kind of anticipate every unique situation, and I think you run into a lot of very unique situations when we're talking about the free clinic patient population. No two situations are identical, but if you can sort of see the overall goals when it comes to eligibility screening, you can usually kind of use logic to find your way through some of those trickier ones. But in terms of what's needed for eligibility screening and the kind of keys, it's about having no health insurance, the signature and date of the patient and screener, screening at least every year, and then certainly those financials. And I think what's key there is that it's the percentage of FPL for each company, and then basing it on the correct household size. What I'm going to do now is get into some nitty-gritty stuff, which actually we have used for some eligibility screener training, kind of giving the overview of why certain things are important, and then some in the format of frequently asked questions, trying to delve a little bit more deeply, but also to be as specific as possible to what situations you might actually be coming across so that you know how to best handle them. So in terms of no health insurance, no prescription drug coverage, I don't know with healthcare reform if there may be some changes in the works in terms of what sort of criteria different pharmaceutical companies employ in the future for patient assistance. But at least for right now, the no insurance is a key element that has to be in place to be eligible for the patient assistance medications. Sometimes there may be on the form a place to say whether you have insurance, yes or no, and people can just forget to circle. They're filling out a big long form and they miss it. That's where the screener, looking at that form and having the patient complete that before they sign off on it, is really, really important. And essentially that's where the checking the no insurance and then an attestation about the truth of the statements in that form is really very key. Just as a side note, because each company is different, but some of the companies require some additional attestations beyond just the truth of the information. They want the patient to be required to report changes in income or insurance status, and then to authorize the release of their information so that the information can be audited. So those are good things if you're looking at redesigning your eligibility screening form to make sure you've got what's needed to participate in the IPAPs on your eligibility screening form. And just as a side note, RX Partnership doesn't have one single eligibility screening form. We require there to be certain elements on a screening form, and so each clinic will have a form that looks a little different, that works for them and their patient population, and may ask additional questions that we don't require but are helpful for the clinic. We look at forms, evaluate them, make sure they have the necessary data elements, and approve them based on that. So there is an ability to individualize and personalize forms as long as you have those elements required. Other thing that's very key, and I showed you on that access system that we use, how we pop in the date of screening in relationship to the date of the product dispensed. It does need to be a rescreening at least once a year. Some clinics may do that more frequently, but in order to be eligible for the bulk patient assistance meds, that's kind of the threshold. So annual screening, things can change, but certainly it's a matter of keeping up with it and ensures the attestation is valid and that household size and financials are current and accurate. This is really key when there may be refills that could extend beyond an eligibility date. You want to make sure that you're doing your rescreenings on a very regular basis, and certainly having systems in place to kind of pop and let you know when folks are about due for rescreening, or to let the pharmacy know when somebody is nearing the end of that time frame, or possibly their eligibility screening has expired. So I mentioned about those frequently asked questions. I'm going to get into some of those, and then certainly if any of you have specific questions, please do type them in. But just as a for example, if you screened someone in June of 2011, but they didn't actually need medication, didn't have a fill until February of 2012, do I need to rescreen them for them to get medication in July of 2012? And you know, the short answer here is yes, but to give a little bit more detail, it is really about that screening date. When they signed and attested and provided those financials, that's when the clock starts ticking. So keep that in mind. Make sure you're on a regular updating of eligibility. And this is where I was mentioning about that refills issue. So I'm saying the best practice here is to have a system that indicates that screenings are due for renewal. Some people are using Excel spreadsheets. Some of them are putting a little reminder on their QS1 pharmacy system. But basically, you definitely want to encourage patients to come in so that there's not a lapse in eligibility. That would be something that can happen at an audit where, you know, they were screened, they were rescreened, but there was a 1 month gap in between, and that's exactly where, you know, something could become a problem, and then you've got a patient who at that time was not actually considered eligible because they didn't have their valid eligibility screening on file. Just to transition to another kind of primary area when it comes to screening is about household size. So we're looking at defining that, and I know it can be challenging. Different companies may define it a bit differently. Different clinics may define it a bit differently. For ARC Partnership, it's most clear to be able to go with the number of individuals who are claimed or would be claimed on the tax return. So sometimes a tax return is not the most current snapshot of someone's income, but it can be extremely useful in determining household size and looking at how to match it up and make sure that you're looking at the right income threshold, federal poverty level, you know, for the program participation. So just to look at a couple questions here that can be tricky, and yet I do find they come up again and again, especially this first one. If you have a situation where you've got a couple, one of them is making $25,000, the other one is making $0. The one who has the $25,000 income is not actually eligible for patient assistance program medications unless, and I know it can happen in some cases where they are actually claimed on the taxes, but more likely than not, they're a separate household from this, you know, kind of perspective. So it's a matter of treating them as such and making sure that you don't have something slip through because of that. Something else that seems to happen, you know, quite a bit is a situation where you might have a more senior person who is living with their children and their family. And so here I've got a situation to sort of describe where you're trying to say what's the family size for that person. And the answer is not simple. It depends. So if the son is claiming his mom on taxes, the family size is 5. But that's where you need the whole family income documentation in order to have what you need on file. But if the son doesn't claim the mother, the family size is 1, in which case she's living with him. He may provide a letter of support in terms of showing how she's living, and then that would go into the file as far as her documentation of her 0 income or her limited income that she might have. So that income threshold, we've talked about that quite a bit in various contexts. Very important to be looking at either what the individual level is for each company that you're participating with, whether it be the individual applications or the bulk programs can vary as well in terms of the income threshold, or as I said, for our partnership, we've gone with the consistent 200% in order to meet the population needs, but also not to have you second guessing which is the right number. So the documentation has to be on file prior to dispensing the medication. I put in here about promises to provide paperwork don't count. We find that, you know, people are well-meaning and they're certainly going to get that to you right away. and then for some reason it doesn't end up happening, and that's a problem. So we've actually even designed some bright orange Post-it notes that we've given out to the 23 different clinics we work with, and it's kind of almost like a little caution warning sign. It says on there what you check a box or you're filling a little note to say, for this patient, until they get you their tax return or their pay stubs or sign their form, they can't get any medication. So think about what systems you can put in place to make sure that you really do have everything complete before you pass that on and that person gets medications filled by the pharmacy. And it certainly is crucial, and sometimes I think this slip happens. On the eligibility form, you can see where they're filling in all the different people in their household and kind of roughly estimating how much they make. But then when you turn to the actual backup documentation of financials, you're finding that you only have something related to one member of the family and not pay stubs for the other employed member of the family. So it's important here to be very thorough and complete. In terms of documentation options, most current IRS 1040, realizing that there is a bit of lag time. This isn't always the best reflection of the current situation for a patient who may have since become unemployed, but certainly until the next tax return is filed, the most current one, like in this case, would be until April 15, 2013, a 2011 tax return is acceptable. I did want to just delve a little more deeply, just noticing some things that can easily get missed by screeners, maybe a new screener particularly, looking at that tax form and realizing that you're looking at gross income. That's very key. But beyond that, there are some things that can show up on a tax return, not be counted under that gross taxable income, and yet need to be considered for patient assistance program purposes. So I think the best way to kind of illustrate this is I'm going to show you the tax return form, basically. And what you'll see here is you've got this line 22, which is where you've got the gross income, the gross taxable income. But what you'll find is there's this box over here, 20A, and this is where I oftentimes can see things that get missed, because you're going to have somebody with Social Security benefits, and there's going to be a certain amount in here. Now that doesn't show up in this column here, so if you were to simply just exclusively look at this line 22, you could actually be approving somebody for eligibility who is over income, because you need to take into account these two numbers. It's less likely for the patient population we work with, but occasionally you might see something in this 15A or 16A. But I think it's just a matter of being as thorough as possible, really looking at the tax returns, making sure you're scanning and evaluating all of these areas and really getting the right number when it comes to calculating income. So as far as other types of financial documentation, you'll see, and probably most of you know and are familiar with, there's a lot of different options when it comes to this. The one thing that I would just kind of pick out and share with you is that a self-attestation of income is not acceptable. This is where it's not okay for somebody to just say, well, I make $500 a month. There's a need when it comes to audits to be able to have some proof of that income. So you really have to work to try to figure out what can you get. Is there a pay stub? Is there a letter from an employer? Is there something that we can get to document that? Now I know it does happen fairly often that you'll come across folks who have cash income. They're working maybe a lawn service or a babysitting service or something like that, taxi driver. I'm not sure how many different types of work could come under this category, but one thing that we found that can be useful to document that, rather than just self-declaring I make this much, as long as there's a detailed log sheet that verifies kind of how much was made doing what job during what time frame, and maintaining those for a period of time, having those on file when it's somebody who doesn't have a traditional pay. So that's one option. So questions that come up related to the income situation. So here we've got somebody who came in for screening, unemployed, and the tax return shows $30,000. Now, typically that's over 200% of poverty level. They would not be eligible, and yet this is a situation if they can provide more current documentation, a termination letter. In Virginia, it's VEC, the Virginia Employment Commission, but whatever your state employment commission is called, oftentimes they'll do a letter maybe showing unemployment benefits for a period of time. That's the kind of information that would be more current than a tax return and be able to have that person shown as eligible. So in this case, with Social Security benefits, they've provided their benefit statement, which is perfectly appropriate, a really good idea to get that benefit statement, but you are definitely looking at the amount before deductions. And you want to double check and make sure that there's not anything being taken out for Medicare Part D. Now, some clinics don't see Medicare patients at all, so this may not come up, but you definitely want to be looking at the right information in terms of what number to use for calculating income. And it may be that there's one person in a family who has the Social Security benefit, the other one is younger, still working. You need to be able to kind of put all that together and see whether that individual, based on their household size and the household income, is eligible. Let's see. So in this case, we've got somebody else who brought in several months worth of pay stubs, and you're kind of wondering what to do. There's a few different ways of looking at this, but I think we're always trying to find people eligible versus ineligible. And so it's certainly important to try to average out, see what someone's income is really like over time versus, you know, seasonal employment or unusual overtime can make them appear over income. But the more that you can do to be able to have more information showing kind of how things average out to that eligibility, or, you know, certainly to look at, is there some other form of documentation available that can go along with pay stubs. I'm kind of in the home stretch here as far as just, you know, a couple more slides to show you before we wrap up and deal with any last-minute questions. But what I've just shown you in this last section is essentially some of the things that you can do to train eligibility folks, to make people at the clinic more aware of how the system works. I think oftentimes front desk staff are the ones who are kind of dealing with the walk-in folks who are trying to determine whether they're eligible or not. So the more that they understand the criteria and why it's important, that can be a good first step. But I do think, you know, some things that you can do and have been done at the clinics that we work with, it's helpful to have a training manual, helpful to have some of these things written down clearly, realizing that, you know, different people retain information in different ways. So I think the manual is a good starting point. I know you're going to train people and, you know, provide information to them, but actually having them shadow a more experienced person for a period of time can be a great way to have them really learn by experiencing it without them feeling put on the spot and like they've been thrown into something before they were ready. It's also a good idea when you've got people who are screening to maybe just every once in a while have somebody checking up on them as well. So I know some clinics that have a head screener who will review some of the newer screeners' work, you know, double checking, making sure that that uninsured box got checked or circled the way it's supposed to, that the patient did sign it and date it. These are the kinds of things that, you know, you have to be very detail-oriented, and sometimes it's just another pair of eyes to double check it, but that's a good practice. I think regular face-to-face meetings, I know some clinics might do this even on a monthly basis. They'll get together over lunch, kind of share horror stories or, you know, those tricky situations they've had come up. And it's a good opportunity to just, as a group, learn from, you know, maybe one person's experience and kind of extrapolate that into, well, hey, is this something we want to add to our training manual? Is this something we want to, you know, get some clarity around so that we can make sure that it's not just this one screener who deals with that next situation in that same way, but that we all are being consistent in handling it that way. It's also, you know, a good idea to look at maybe a PowerPoint that encapsulates some of the different information from your training manual or from your different training sessions. Things like the slides that I went through, Rx Partnership shares out with the different clinics in case they want to incorporate that into their own eligibility training that they might do locally. So, you know, just having an opportunity, maybe even to have people on their own kind of click through the PowerPoint or to do it as a group, being able to benefit from some of that information. So with that, that kind of wraps up the overall presentation. I feel like I've gotten to what we said we would in terms of learning a bit more about IPAPs, a bit more about screening, the self-auditing. I'm not sure, I know some people in the original poll had said kind of other for what they were hoping to get out of it. if you do have some questions that you want to submit in that I can, in the next, say, 5–10 minutes, be able to provide you with a little bit more information, I'm happy to.
Okay.
So I guess I'll turn it over to you to see if there's any questions.
Okay. Well, thank you very much, Amy. That was very informative. There was a question about getting a copy of the slides. Can they just email you at that email address to get a copy?
Sure.
Okay.
Not a problem.
Okay, there's a question about figuring out household size. Is it best practice to go off who's claimed on the taxes?
I think so, definitely. And I mean, true, it's a point in time. You know, the person may have had a change in circumstance since then. You know, they were a household of 4, since got divorced, so the household size has changed. But I think what they're reporting into the IRS, what they're attesting to them, is a good guide. You may be looking at even more updated financials from another source, but we tend to look at the tax return as a good guide to what the household size should be, because there's a lot of kind of fuzziness as far as, you know, is that elderly parent claimed or not claimed? Is the person who's taking care of their grandchildren, you know, actually kind of taking care of them long-term and permanently, or is this just a temporary situation? It seems like that's the most kind of supportable way to look at household size, have some documentation.
Okay. So I think we'll have time for one more question. Before we get to that, just wanted to mention that NeedyMeds does hold our regular monthly webinars going over our resources, and we started doing these special topic webinars, so you can always check back to our webinar page to find out about upcoming webinars. And if you want to, you know, suggest a topic for a special topic webinar, you can always get in touch with me for NeedyMeds related questions. I'm Elizabeth Messenger. And you should have all received an email from me, but I'm elizabeth@needymeds.org if you do have NeedyMeds specific questions. So we have one more question about, is there a broker in Maryland?
At this point, from what I understand, there used to be MedBank of Maryland, but now I believe it's been taken over, and there's something for Montgomery County that is doing a bulk situation for, I believe, that region. So beyond that, I don't think there's a necessarily fully statewide program. But this is where part of the reason that I kind of share what our partnership does is that our approach is unique, and we were the first ones to kind of pioneer this broker model because it is very cost effective. We don't have to have a big warehouse and maintain a pharmacy staff. That's kind of how we got started in Virginia and why. But I think our approach is also something that can be replicated. And so if there's anybody out there in a state that doesn't have access to kind of a state coordinating program for medication access, there would still be the need to kind of start your own initiative and form those relationships with pharmaceutical companies. But in terms of setting up a program that in many ways mirrors our partnership, it's completely you know, appropriate to look at doing something similar, following some of the same systems and steps that we might have, but implementing that in another state.
Great. Okay, well, I think we'll wrap up. Thank you so much, Amy. That was really helpful, and I hope everyone learned about IPAPs and have some better information moving forward if you want to look into setting up one. And again, I'm sure you can contact Amy for any questions you have about the presentation or if you'd like copies of the slides. And I hope everyone has a great rest of their afternoon. So thank you again, Amy, and thank you all for attending.
Thanks, everybody.